So we're going to move into the gastroenteritis section. We are going to talk about probably the most bugs here that we will across all the different conditions, because I really wanted to try to give us some context of how we can separate these different causes of GI distress. So gastroenteritis, infection-driven inflammation of the gastrointestinal mucosa. Most of the time, small intestine or large intestine. The main event is going to be injury to our intestinal epithelium and/or disruption of electrolyte transport. That's the diarrheal component. We'll have fluid loss that manifests as diarrhea, sometimes vomiting. On NPLEX, our first major branching point is going to be watery versus bloody diarrhea. So that's going to be what we're looking out for. That will narrow down our organism list. A second key distinction is going to be toxin-mediated disease versus invasive disease. Toxin-mediated, we're going to see they're secreting some type of toxin that's causing pathology, versus invasive, they're actually invading into the tissue themselves. So that will help us with timing, fever presence, stool characteristics, etc. So what are these toxins? This is not an exhaustive list of toxins, okay? So this is talking specifically about exotoxin containing gastroenteritis causing bacteria. So this would be our 4 major bacteria that cause a toxin-mediated diarrheal illness. This would be watery diarrhea that does not have significant inflammation, not likely bloody stool, okay? So significant difference, although there's one that is kind of separate in this statement. But we'll get there. So Bacillus cereus, this produces 2 toxins, a heat stable, which is associated with rapid onset vomiting. This is your classic reheated rice infection, or your bad, poorly stored rice. And then a heat labile toxin, so be easily broken down with heat. And this is more the watery diarrhea that occurs hours later. So Bacillus cereus, bad rice, or poorly stored rice, or poorly reheated rice, and it has both a heat labile and a heat stable toxin. Heat stable, vomiting; heat labile, diarrhea, watery. We have 2 E. coli listed here. We have an enterotoxigenic and an enterohemorrhagic. So enterotoxigenic is ETEC, E-T-E-C. This gives us a heat labile and a heat stable enterotoxin that increases either cyclic AMP or cyclic GMP. Either one of those is going to drive chloride to move out of the cell into the lumen. And if chloride's moving, sodium's moving. If sodium's moving, water's moving. So we're going to have water traveler's diarrhea, really watery diarrhea that's occurring because we're losing these chloride ions, we're losing this salt, we're losing this water. So it's our enterotoxigenic, or ETEC, E. coli. Our enterohemorrhagic, or EHEC, this produces a Shiga-like toxin. So this looks like Shigella. It inhibits our 60S ribosomal subunit. Yes, you need to be that specific with knowing the mechanism here. So 60S ribosomal subunit. That leads to damage of the endothelium, and this is our first potential bleeding risk. We have risk of hemolytic uremic syndrome as well. Antibiotics tend to be avoided in this condition. And we're going to come back to EHEC, so we're not leaving this fully. I just wanted to compare the 2. And then we have Staph aureus. This causes food poisoning. This is from preformed enterotoxin B, which is a superantigen. This massively activates T cells via MH2 CD4 interaction. And the key clue is going to be a rapid onset. So this is the fastest onset food poisoning, the Staph aureus. So you ingest something, rapid onset symptoms, think Staph aureus. We're going to break them all down. They're all going to get their own slide. So we're going to go in depth in all of these bugs. Hours. Like, could be within 30 minutes. 30 minutes to an hour, think Staph aureus. Typically, it's between 30 and 120 minutes. So like 30 minutes to 2 hours. Yeah. Okay, so think Staph aureus food poisoning. So speak of this one. So this is classic rapid symptom onset. So if you have a gastroenteritis, really quick onset, 1 to 6 hours, the toxin is preformed in the food. So you eat the toxin. It's not being produced in the body. You're ingesting the toxin. It's not produced in the gut. That's a key distinction. So what causes the symptoms in Staph aureus food poisoning? It's the preformed toxin that you're consuming, not the bacteria itself. Symptoms are dominated by nausea and vomiting. You can or cannot have diarrhea. It tends to be more mild, the diarrhea, and fever is not often present. It's often absent, so no fever. Because it's toxin mediated rather than an infectious invasion, an antibiotic wouldn't help because it's the toxin. The toxin has to pass, it has to stop doing its damage. On NPLEX, if you see here, rapid onset, creamy food, improperly stored meats, think Staph aureus. Okay, that's going to be your key. I listed a couple components to the bacteria itself. If you want to, some bacterial characteristics on each of the slide. I typically include the gram, the morphology, and then some of the kind of bio or like microbial components, like is it catalase positive? What does it like to do with oxygen? Does it have any hemolysis effects? And then sometimes I'll list like any special virulence factors. So that's what this last section is. I may or may not always mention these, but they're always here on these slides. Our next food poisoning is going to be Clostridium perfringens. This is through ingestion of spores. So Clostridium is one of our gram-positive rods that can create a spore where it can actually kind of be suspended in like suspended animation, where it's not actively dividing. And that's why it can withstand a lot of different like high heat and inopportune conditions. So this bacteria is really able to survive a lot. The ingestion of these spores, they germinate in the intestine, and then once those spores germinate, kind of like essentially sprout, go back to normal, they release an enterotoxin. So symptoms will be a little bit delayed compared to Staph aureus, 8 to 16 hours. You're still having symptoms though on the first day. After ingestion, you'll have watery diarrhea with abdominal cramping. So Staph aureus, really no diarrhea or mild. Clostridium perfringens, really watery diarrhea, severe diarrhea and cramping. No vomiting and really no fever. So very similar to Staph aureus in that you're not seeing a fever here. This is commonly associated with meat dishes or gravies that were improperly, oh wait, sorry, I'm on the wrong slide. There we go, improperly reheated. Again, this is toxin mediated and usually self-limited. So Clostridium perfringens, that's what I've been talking about this whole time. That was Bacillus cereus, Clostridium perfringens. Okay, so again, Clostridium perfringens travels in the soil, creates a little spore. Spores germinate in the food or germinate in your gut, releases enterotoxin, no fever, watery diarrhea, really no vomiting, not really a bacterial infection to the same degree, often self-limited. No antibiotics needed. Okay. Now going back to Bacillus cereus, this is another toxin-mediated food poisoning organism. It has two distinct syndromes. The emetic form, vomiting form, happens right after ingestion. And this is reheated rice. So if you hear rice, it's Bacillus cereus. It's nothing else. That's all it is. And that's due to the heat stable toxin. The diarrheal form is from the heat labile and enterotoxin in the intestine. Like Staph aureus, this is also self-limited, and antibiotics are not indicated because it's toxin mediated. It's not the bacteria causing the problem, it's the toxin causing the problem. So how do I separate those three? Staph is the fastest, Bacillus is rice, and it has vomiting and diarrhea. Clostridium, just diarrhea, also pretty fast, but no vomiting. All three, no fever. All three, no antibiotics needed. That's how I'd separate those three. Okay? Yes.
If I can ask this question. But is it for both Clostridium and B. cereus, the bug, the bacteria form in the food, you ingest the food, and then the symptoms are caused by the toxin released by that bacteria.
Correct.
It's true for both.
For both. Yes, one meat, one rice. One likes hanging out in the rice specifically because the one with the rice has both heat stable and heat labile toxins, meaning that it can survive the enterotoxin itself can survive the reheating of the rice, and that bacteria itself loves to thrive in rice. That's where it tends to eat and thrive. But both our Bacillus species and our Clostridium species look and feel very similar. I think of our Bacillus as really like watery diarrhea. I think of our Clostridium as also having watery diarrhea, but the difference is our Bacillus can have a lot more vomiting versus our Clostridium, we oftentimes don't see as much, if any, vomiting. Okay, now we get to ones that are a little bit different. So first we're going to talk about Shigella, because then we'll talk about E. coli and we'll talk about Shiga-like toxin. But we need to know what Shiga toxin or Shigella looks like first. So with Shigella food poisoning, Shigella causes invasive dysentery. So Shigella is our first one that's actually invading into something. It means bloody mucus-containing diarrhea with full systemic symptoms. It also produces Shiga toxin, which inhibits our 60S ribosomal subunit, though it typically has less risk for hemolytic uremic syndrome than EHEC. So Shigella, its main kind of pathology is it's invading into our cells and it's causing bloody, mucousy, watery diarrhea. So all the things, because it's invading into the cells, destroying those cells. It also then releases a toxin which stops proteins from being created by affecting our ribosomes. And so that is kind of its secondary pathology. E. coli can hijack and steal Shiga-like toxin. It's not quite the same, but it acts in the same way. And that's where our EHEC can look sometimes like Shigella, because it takes a toxin that acts very similarly to Shigella toxin or Shiga toxin. So pathologically, Shigella is notable for its ability to invade into our Peyer's patches and our M cells. It then can escape the phagosome, so it can escape macrophages, the phagosome, from phagocytosis. It then can spread from one cell to the next without having to go through the blood. So it really does a good job at evading detection. It's also acid resistant, meaning that transmission can occur via a very low infectious dose. It can resist the destruction from our hydrochloric acid in our stomach. It makes fecal oral spread pretty common, especially in daycare institutional-like settings. It's gram-negative, non-motile, it's catalase positive. It can deal with no oxygen, doesn't have to have oxygen or not have oxygen. It's a facultative anaerobe, and it's bacilli. It's a rod. If you think of dysentery, daycare exposure, low like inoculum, so low amount of bacteria, bloody mucus, that would be an increase in risk for Shigella for me, those types of pieces. Doesn't move, non-motile. Versus E. coli. E. coli-based food poisoning. So Escherichia coli can cause lots of different things. It has multiple pathogenic strains. NPLEX will expect you to differentiate them by mechanism and stool type. So the two I'm really talking about the most here are ETEC and EHEC. If I had to simplify them, ETEC is watery, EHEC is bloody. That's how I'd simplify them. Now, there's more like flair that I'll talk about with those two, but at its base, ETEC watery, EHEC bloody, both E. coli. That's where I would start. So with ETEC, it's a watery diarrhea and there's no inflammation, meaning I'm not sloughing off the cells of anything. It's not evading. And that's partially because it has a heat, labile, and stable enterotoxin. That's the ETEC. It's increasing electrolyte and fluid secretion into the intestinal lumen, but I'm not destroying the cells. I'm just increasing fluids. That's that watery diarrhea of ETEC. Versus EHEC, EHEC is bloody diarrhea because of Shiga-like toxin. Shiga-like toxin acts like Shigella. It's going to inactivate the ribosomal 60S subunit. That means decreased proteins and enterocyte, or the cells that line the intestinal lumen, death. So we're killing off our cells that line. We're going to see blood. We're going to see mucus then. We're going to see inflammation. That's our EHEC. There is also EPEC and EIEC. EPEC would be the pediatric version of watery diarrhea for E. coli. So if it was a young kiddo who had E. coli exposure, so gram-negative rod that's mobile, you could think of EPEC, which is the pediatric watery version. It has an enterotoxin. It's not destroying cells. EIEC is also invasive. It's dysentery-like illness, but there's no Shiga toxin. So that's how you differentiate EIEC from EHEC. They both invade, but one does so with Shiga-like toxin, that's EHEC. The other just invades, but does not use Shiga-like toxin, that's EIEC. Would I memorize all four? Probably not. I'd memorize these two, ETEC and EHEC, and then I'd try to be able to work my way out of being pulled away for an answer choice for any of the other E. coli options. Okay. They'll typically give you a mechanistic clue rather than naming the strain outright for your answer choices. Now, there's two types of typhoidal food poisoning that we'll talk about. We'll talk about non-typhoidal salmonella food poisoning, and then salmonella typhi, typhoid fever food poisoning. So for non-typhoidal salmonella, this is typically an inflammatory diarrhea, often associated with undercooked poultry, eggs, or reptile exposure. That's the weird one. So for me, anything weird on NPLEX, I'm putting together in my brain, often with fever. It invades the intestinal epithelial cells. So again, it's invasive. It survives inside of macrophages. Unlike Shigella, it needs a higher infectious dose because it can't resist stomach acid. So you need a lot of bolus, a lot of exposure to non-typhoidal salmonella to actually have an infection occur because it'll get destroyed in stomach acid, as it should. In an immunocompromised patient, salmonella could lead to bacteremia. That would also be a key distinction. Versus salmonella typhi food poisoning. This is typhoid fever. This is the bacteria that causes typhoid fever, systemic illness. This is not just an isolated gastroenteritis. There's going to be a stepwise fever that occurs, abdominal pain, rose spots, and bradycardia. It'll disseminate, it'll spread through the blood hematogenously. It does so after crossing our intestinal epithelium, so it can invade, get into the blood, and then it lives inside macrophages in our reticuloendothelial system. So our macrophages, they're kind of hanging out in the reticular fibers that are supporting our blood vessels. That's where it hangs. Patients who become chronic carriers, they're typically infected in the gallbladder. So that's where it likes to hide, is the gallbladder. That's a classic board association. So salmonella typhi, if there's someone who is a colonizer or someone who's colonized or an asymptomatic carrier, it is in their gallbladder, likely in a macrophage. So you'll always want to distinguish salmonella typhi from non-typhoidal salmonella. Salmonella typhi, typhoid fever, systemic illness. Non-typhoid salmonella, that's your classic food infection with salmonella, your classic gastroenteritis food poisoning. Yersinia enterocolitica, I mean, this would be a less common gastroenteritis, but still can occur. This would be bloody diarrhea. It mimics acute appendicitis. That would be my key clinical tie because it can actually affect and cause lymphadenopathy in the mesentery. So you can get mesenteric lymphadenitis. Undercooked pork and unpasteurized milk are your associations. Yersinia, a key pearl that makes this unique, Yersinia grows in the cold. So that's why refrigerated foods, there can still be transmission. So Yersinia looks like appendicitis, bloody diarrhea, undercooked pork, unpasteurized milk, likes the cold. Any Stranger Things fans, just think of Will. I like it cold. Okay. Campylobacter jejuni, food poisoning. This is curved gram-negative rod, undercooked poultry, unpasteurized milk. And pasteurized milk, when in doubt, is like all of these. But undercooked poultry and unpasteurized milk. This is an inflammatory, so cell-destroying, often bloody then, diarrhea with a fever. It also, Campylobacter, it's kind of key association. So in a Campylobacter gastroenteritis is associated with post-infectious Guillain-Barré syndrome. So this patient, if they have Guillain-Barré, which is kind of that numbness and tingling or weakness that can occur post an infection, think Campylobacter. Or if they say, what's a sequelae or complication from a Campylobacter gastroenteritis, think Guillain-Barré. So tie them together. This is because of molecular mimicry. So it's essentially antibodies to Campylobacter jejuni mimic our neurologic system that gets attacked in Guillain-Barré. So that's why that happens. We talked about a little bit about Listeria already in regards to meningitis, but Listeria can cause a febrile gastroenteritis in healthy individuals. It's most dangerous in pregnant patients, neonates, elderly, and immunocomp individuals, soft cheese and deli meats. This is why we ask pregnant patients to avoid these things. And beyond GI, we already know it's associated with meningitis. So that's your other key tie-in. Okay. We're going to move now from bugs or bacteria to some viruses. There's 3 key viruses that I want you to tie in with your gastroenteritis. Norovirus being the first. This would be the most common cause of viral gastroenteritis in adults. So think noro. If the patient's an adult and you're thinking viral, think norovirus. Spreads via fecal-oral transmission as well as contaminated surfaces, especially in a closed environment. So this is your classic cruise ship, nursing home exposure, conference, etc. Acute onset vomiting, watery, not bloody diarrhea, with rapid spread through populations. So it's just supportive treatment. So if they talk about a cruise ship, I am saying norovirus before I even think of anything else. My second one would be Legionnaires, but that would potentially be a non-gastroenteritis if it was like a different type of infection. Rotavirus gastroenteritis is leading cause of severe diarrhea in children, which is why there's vaccine for this, especially infant diarrhea. It's profuse watery diarrhea. This is because, again, it destroys enterocytes. It can break down or disrupt sodium glucose transport, so it can affect hydration and actual feeding. Vaccinations reduce disease, but it still remains board relevant, especially in a pediatric context. So viral adult, noro, viral peds, rota. The last one is adenovirus. Adenovirus causes gastroenteritis in young children, has more prolonged symptoms compared to noro or rotavirus, so it'll last longer. It's a non-enveloped virus, so it's in resistance to breakdown in the environment, which is why it's more transmissible. But this is less common. If it was like a subacute gastroenteritis, then I would maybe look at adenovirus. So tying this back to our structures that are located here, thinking about our large intestines, the main primary function in our large intestine, remember, is water and electrolyte absorption, formation of feces and storage, as well as microbial fermentation. Disruption of any of these processes, especially water absorption, explains why any colonic infection causes frequent, smaller volume stools rather than like a massive watery output that's seen in small intestinal disease. Histologically, the colon is lined by simple columnar epithelium. They don't have villi. They have lots of goblet mucus secreting cells. There's tinea coli, which are 3 longitudinal smooth muscle bands. They create haustra, which are the out pouches that we see in the large intestine, the little pouches that occur that you can see on gross anatomy and imaging. And these are frequently tested structures in anatomy and micro integration questions. So just key components to remember. Vasculature, what we were talking about over break. So from a vasculature perspective, the blood supply in the gut follows the embryologic origins. That's when we care about like foregut, midgut, hindgut, is only really primarily in the gut vasculature. It's really where we're paying attention to this. So mid-gut derivatives coming from the middle portion of our developmental tube is the proximal portion of the colon. This is supplied by our superior mesenteric artery and its branches. So that'd be the ileocolic, the right colic, and the middle colic arteries. Hindgut derivatives, that would be the latter portion of our colon, the distal portion. This would be our inferior mesenteric artery branches, and this is from the hindgut, so left colic, sigmoid, and superior rectal arteries. Venous-wise, we drain via the superior mesenteric vein and the inferior mesenteric vein, and those feed into the portal vein through the liver. That's kind of relevant when we talk about things like portal hypertension or hepatic metastases. Rectal blood supply of note is mixed. So rectal blood supply links kind of portal and systemic circulation. So we have blood flow between both systemic circulation and portal liver circulation. The other component of the gut to note from an anatomical perspective is our retroperitoneal structures. They love asking about this. It's so not clinically relevant unless if you're ordering imaging. But ascending and descending colon and part of the rectum are retroperitoneal for like the large intestine structures. There's so many different like mnemonics and things you can remember or memorize. Whatever works for you, it doesn't matter, but you should be able to list off. This slide lists the primary and secondary retroperitoneal structures, but you should know which structures are retroperitoneal. From there, if you know the retroperitoneal structures, the ones that are in the back, you can assume that anything that's not on that list is not retroperitoneal. Then you don't need to memorize like where it is in the abdominal cavity. Okay, we have another stem. So this is going to be gut anatomy, embryology, vascular supply. So the question is going to be which vessel was most likely damaged during the initial phase of the appendectomy, and we have blood vessels. So ileocolic, left colic, middle colic, right colic, splenic arteries. It's like a nightmare question on NPLEX, but it's super common. Okay, so when we're looking at this, we need to know who supplies what. So we need to know who supplies the appendix, essentially. So when you're studying anatomy, my key component for 1 month left is look at your major organs of the body and know what blood vessel, what artery feeds that organ. That's going to be your key tie From there, if you're able to work that artery back to its mother, the like main artery it branches off of, whether it's the aorta or like the right or the superior mesenteric or inferior, whatever, great if you know who the mother is of that artery. And then if there's any fun structures it passes through along the way, right? Like in the brain, we have the foramen. Sometimes in the gut, there's different like holes or things. I think of the most infamous, the diaphragm, right? What's passing through where. Those would be important structures. Otherwise, it's really organ and who feeds the organ. That's what I'd focus on. I'd do gut. I would do repro structures, so your organs, reproductive organs. I would do brain, major brain structures, and then the heart. Those would be my areas I'd focus on first. If you have all those down, then you can go muscles, skeletal muscles. But that'd be secondary after you know your organ suppliers. Okay. So looking at our stem, we have a 27-year-old male. He presents to ER, nausea, diffuse colicky pain around the periumbilical region. There's tenderness in the lower right abdomen upon palpation and deep pelvic pain with extension of the hip joints. They're just telling us that he has appendicitis, which is confirmed, like a classic NPLEX stem. We have the thing confirmed. Laparoscopic appendectomy is performed. The surgeon notes the presence of blood within the peritoneal cavity following the removal of the appendix. Which vessel was most likely damaged? So it's truly asking, who is the blood vessel that serves the appendix, or was the most likely blood vessel that supplies the appendix? So if we think about first, superior versus inferior mesenteric, who is of the superior versus inferior mesenteric, who's more likely to supply the appendix? We can think of like the initial part of our large intestine is superior. The distal or latter part is inferior. The appendix is on the beginning of a large intestine. So more likely the superior mesenteric artery, the SMA. You would be correct with that logic. So all if you knew, SMA is the beginning of the large intestine, IMA is the end, appendix at the beginning. That would help you narrow down because now you know the mother, right? Now you're like, okay, well, who are the arteries that come from the superior mesenteric artery branch, right? So then we have to think of, well, who are the branch points? We could go back a couple questions, and we have the ileocolic, the right colic, and the middle colic. So if we look here, so ileocolic, right colic, and middle colic. So we've got narrowed down to 3 now. Okay, in NPLEX, there's only going to be 4 answer choices. So we got narrowed down, we got 2 off. Now from here, this would be where knowing who supplied the organ would be the most helpful. They want to have a guess that they want to do or know what it is? Yeah, it is. It's ileocolic. Heck yeah, there you go. So ileocolic artery is the terminal branch of the superior mesenteric. It's the only answer listed that directly supplies our appendix. It goes retroperitoneal toward right iliac fossa, gives rise to branches that supply the terminal ileum, the cecum, the ascending colon, and the appendix. The ileocolic artery gives rise to the appendicular branch that travels between the layers of the mesoappendix to supply it. You don't need to know any of this. You just need to know this supplies the appendix and it comes from the mother, the SMA. That's its mothership. So again, knowing organ artery is going to serve you well for your anatomy questions. It's our highest yield anatomy stuff at this point would be organ artery. Okay. How are we doing so far? Okay, I'm gonna power through spinal cords and then we can break again. So this spinal cord infections are high stakes because they involve direct injury to neural tissue, often giving us permanent neurological deficits. These are not just tested as infections, but mechanism-specific neurologic syndromes. So it's going to kind of tie into recognizing upper versus lower motor neuron involvement, ascending versus descending paralysis, and toxic mediated versus inflammatory damage. A lot of these pathogens act through neurotoxins or selective neuronal vulnerability. So looking at tetanus first, tetanus is Clostridium tetani is your bacteria. Anaerobic, doesn't like the oxygen. Spore forming, can live long time in the soil without having to divide. Gram-positive bacillus, rod. The organism itself does not invade the central nervous system. It produces a tetanospasm or spasmin, which is a neurotoxin. So the bacteria is not what's invading. It's its neurotoxin that's causing the damage. It's causing the problems. So mechanistically, the neurotoxin tetanospasmin is transported retrograde, so it's walked along the motor neurons, so up the motor neurons towards the central nervous system. That's retrograde transport. It then is going to block release of inhibitory neurotransmitters, GABA and glycine. Those are your big inhibitory neurotransmitters. These are from interneurons in our spinal cord. It's going to lead to an unopposed excitatory motor neuron activity, and that's how we get the spastic paralysis seen in tetanus. We can't stop the contraction. The control is gone. We've taken the foot off the control. Clinically, you'll see trismus, lockjaw, rhizus, sardonicus, which is the painful muscle spasms. It almost looks like the movie Smile. Has anyone seen the horror movie Smile with like the creepy smile and the eyebrows raised? Yeah, that's kind of what rhizus, sardonicus it looks like. If you know, you know. If you don't, look up Smile, the movie, and that is the look. It causes the classic ophthotonos, which is the muscle spasm with the arched back position. Those would be all like kind of key words or key things that you could see. But really, it's going to be a spastic paralysis, and it's classically compared to botulinum toxin. So this is like our compare and contrast. So tetanospasmin, retrograde transport. It's going to block inhibitory neurotransmitters, GABA and glycine. It's going to affect interneurons. It's going to then lead to unopposed excitation of our motor neuron activity, and we get spastic paralysis. Classic, I stepped on a nail, rusty nail. Botulinum or Clostridium botulinum is the bacteria. This is the physiologic opposite of tetanus. So botulinum toxin acts at the presynaptic terminal of our cholinergic, so nicotinic and muscarinic neurons. It's going to cleave snare proteins. It blocks acetylcholine release at both nicotinic and muscarinic synapses, and it's going to lead to a lower motor neuron dysfunction. So we get descending, symmetric, same side, flaccid paralysis. So we're not contracting where we can't contract, absence of contraction. Cranial nerve involvement happens early, so we see diplopia, dysphagia, dysarthria, xerostomia, mydriasis is classic. In infants, you could see honey spores being an association. They're getting spores in honey that could lead to floppy baby syndrome, essentially flaccid paralysis of the baby, of the infant. If you see descending paralysis, autonomic symptoms, think botulism. If you see honey and infant, think botulism. If there's any conversation about snare proteins, you can think of botulism and a few other things, but botulism is one of those things. So if you see snare, you can be like, oh, maybe botulism, botulinum toxin. Okay, kind of jumping here. We don't often talk about these as much, but they are still in the spinal cord infections, and they're totally fair game to be tested on. So rabies is a Lissa virus, which is a negative sense single-stranded RNA virus, which means that it doesn't have to, it can be converted into proteins, right? Because it's already in its RNA form. So it doesn't have to be converted into RNA. It's already in its RNA form. It's from the Rhabdoviridae family. How much should you memorize the families? Some years it's really helpful to memorize families of viruses. Some years it's not helpful at all. So if virus families stick in your brain, great. If they don't, I wouldn't commit as much time to them, but I would know kind of the key pathologies with these viruses. So rabies, Lissa virus. Saliva from an infected animal bite is transmission. It binds to nicotinic acetylcholine receptors. This is at the neuromuscular junction, so on the muscle. It then moves retrograde, so it walks itself up the peripheral nerves axons to get to the central nervous system. Histologically, rabies produces Negri bodies, which are eosinophilic, so kind of pink staining cytoplasmic inclusions, so pink staining stuff that happens inside the cytoplasm. We see them specifically in the Purkinje cells of the cerebellum and hippocampal neurons, so neurons in the hippocampus. Clinically, you'll see hydrophobia as your big thing, fear of water. We think of Michael Scott in his infamous 5K, photophobia, autonomic instability, seizures, and progressive encephalopathy. Ultimately, respiratory failure is how people die from this. Once symptoms happen, rabies is almost universally fatal. So that's a key component for rabies from like a prognosis perspective. So treatment is really has to be post-exposure, right after the bite. So again, rabies and tetanus both have retrograde transport to the central nervous system. Rabies, though, is dealing or affecting our nicotinic receptors, binds to our nicotinic acetylcholine receptors, versus our tetanus is affecting our interneurons in our spinal cord, so different location that's affecting. Those are ways you could kind of tell these things apart. Obviously, exposure is different. Polio. Poliomyelitis. Poliomyelitis is caused by poliovirus, which is an enterovirus. So I mentioned earlier, like enteroviruses could cause stuff. Poliovirus is an enterovirus. It's a positive sense single-stranded RNA virus that's already in RNA form. Transmission fecal oral here. Initial replication occurs in the gut, and then it spreads via the blood, hematogenous spread. The virus will invade the anterior horn cells of the spinal cord, so the front kind of portion that sticks out. These are lower motor neurons. This leads to an asymmetric acute flaccid paralysis. So we had a symmetric flaccid paralysis, botulinum. We have an asymmetric flaccid paralysis. That's going to be polio. So one-sided polio, two-sided botulinum. Oftentimes, the paralysis here with polio is worse, more proximal than distal. So the further away from center, the worse the paralysis is. So hyporeflexia, hypotonia, fasciculations, weak atrophic muscles. Eventually, if the diaphragm becomes involved, that's what leads to respiratory failure and death from polio. Typically, if you see an asymptomatic or asymmetric lower motor neuron paralysis without any sensory loss, you think polio or some other anterior horn pathology. But polio would be the big one that I would think of. Yeah. Proximal is worse than distal. Yes. So sorry, proximal, I think I pointed to the wrong space, so online people didn't get confused, but folks here, yes. So proximally worse, distally better. The other condition where you see proximal worse is myasthenia gravis. Not infectious, right? Rheumatologic autoimmune, but in myasthenia gravis, proximal muscle weakness is more likely associated versus distal. So those would be two proximal associated conditions, would be polio and myasthenia gravis. Polio, infectious, myasthenia gravis, not. Thanks for clarifying. Sorry for acting it out wrong. Okay. Next one is neurosyphilis or tertiary syphilis or Tabes dorsalis or syphilitic myelopathy. These are all saying the same thing. So Tabes dorsalis is a manifestation of tertiary syphilis caused by Treponema pallidum, the bacteria that causes syphilis infection. In this pathology, you'll see a demyelination of your dorsal columns and dorsal root ganglia, so dorsal dorsum, dorsal fin, the back. Because the dorsal columns help with proprioception, vibration, and fine touch, patients will have sensory ataxia, broad-based gait, kind of like what you think about with Parkinson's disease, with a broad-based gait, but different etiology. They also have a positive Romberg's sign. Reflexes will be diminished in lower extremities because of dorsal root involvement. And this would be kind of a classic bridge condition between infection and neuroanatomy. So oftentimes when they ask a question about tertiary syphilis, they're really asking about sensory pathway localization. So they're asking like an anatomy question within a tertiary syphilis question. They'll be like, it's affecting the dorsal root and you have weakness in X muscle in your lower extremity. What's the nerve that innervates that muscle? It'll be a totally not related syphilis question. There'll be an anatomy question. It's oftentimes what they do with tertiary syphilis. Okay. Some other things to consider here. These are some either non-infectious or outside of the spinal cord causes of spinal cord dysfunction that could appear in an infectious differential. So Diphyllobothrium latum, which is just fishworm, this competes for vitamin B12 because it breaks apart intrinsic factor and B12 complexing, leading to a B12 deficiency. H. pylori causing chronic gastritis, parietal cell loss, reduces intrinsic cell production, intrinsic factor production, which then leads to loss of B12 absorption, B12 deficiency. And B12 deficiency in any condition or state can lead to a subacute combined degeneration that affects dorsal columns, lateral corticospinal tracts, and spinocerebellar tracts. So essentially affects a lot of different tracts that are running up and down our spinal cord, communicating from our brain to our body. So clinically, that could look like loss of proprioception, spastic weakness, hyperreflexia, and a megaloblastic anemia. And so this would be how we could see potentially like a GI, pathology, biochemistry, neuroanatomy connection, right? B12 deficiency. So I'm assuming a lot of you have tried to block out the anatomy of the spinal cord and all the tracks I've talked about here, because I wouldn't blame you. I have to relearn it every time I teach it. So just basic first, anatomy of the spinal cord, gray and white matter. Gray matter has our neuron cell bodies. It's where our synapses integrate. White matter is going to be our ascending and descending axon tracks responsible for sending signals. And understanding which structures are affected will help you localize a lesion. So our ascending pathways as a whole, so this is going to be on the right in blue, all of our ascending pathways are sensory, right? They're giving the central nervous system information. That's why they're ascending upward. Their receptor is peripheral, and it's sending information to the spinal cord, and then that ascending pathway in the spinal cord sending information upstairs to the central nervous system. Versus a descending pathway is sending a motor command from the central nervous system. So descending pathways are always going to be sending some type of motor action from the central nervous system downward. Doesn't necessarily mean skeletal motor, but some type of motor. It's some type of signal going to an organ or some type of effector. Many of our spinal infections and degenerative diseases will affect one pathway over another. And so that's how we can predict neurologic damage. And we can test these different types of pathways. So I'm just going to focus on a couple pathways right now. So I'm not going to go a huge neuroanatomy lecture, and then we'll take a break. But I first want to focus on our two pyramidal tracts, our lateral corticospinal tract and our anterior corticospinal tract. So corticospinal, cortex, cortico, spinal cord, right? So that's where the tract is running, cortex to spinal cord. Then it's going to synapse, and then it's going to exit because it's a descending pathway. It's going to exit into the periphery and innervate some component, some effector, some organ. So our lateral corticospinal tract controls distal, so things further away, limb muscles, especially ones involved in fine-skilled movements, writing, playing the piano. Playing the piano is the classic kind of combo for lateral corticospinal pathway. This pathway starts in the motor cortex, goes through the, I think I have most of the things here. Yeah. Starts in the motor cortex, goes through the corona radiata, passes through the internal capsule, then it's going to move down through the crus cerebri. It's going to decussate all the way down here at the medulla. Decussate means crossover, decussation, right? It's going to cross over from one side to the other. So if it starts on the right, it's going to cross over at the medulla oblongata to the left, or the medullary pyramid, the medullary pyramids, which is in the medulla oblongata. From there, it's going to move downward via the lateral corticospinal tract. We see this here. Then it's going to move to the ventral horn, which is the lower motor neuron, and then it's going to escape and go to skeletal muscle. So that's your kind of pathway here. Would I memorize this pathway? I would know this pathway. This is a pathway I would want to know, want to be able to follow, and I would know where it decussates. 90% of fibers, of corticospinal fibers, crossover. They decussate. 10% don't. The 90% that do are lateral. So this is the 90% would be the lateral corticospinal pathway. Damage above decussation, damage above the crossing over point, will produce a contralateral upper motor neuron sign, while damage below the crossing over point will produce an ipsilateral deficit. So if we think about that, if I have something that's starting on, let's just say it's starting here on my, we'll just say left side to make it easier. Because yeah, that's what we're looking at. We'll say actually, if we're looking at the human, it'd be the right side. So we'll say right side. We'll say this is the right, okay? This is the left. So if I have a lesion that's starting on the right side, this is above my decussation point. My tract is coming down over here. So if I have a lesion above, I'm going to have contralateral damage, right? So it's going to be opposite of where the lesion is. Versus if I have already crossed over and I have damage below this crossover point down here, I'm going to have ipsilateral, same side damage. So wherever the damage is, I'm going to have same side effects. That's all this is saying. It really just matters, is it before the crossover point or after the crossover point? So if you know the crossover points at the medulla, anything above the medulla, opposite side, contralateral. Anything below the medulla, same side, ipsilateral. This is specifically for the corticospinal pathway, but you could apply this to any pathway that crosses over. So any pathway that decussates, if it's above the crossover point, then it's going to be contralateral. If it's below the crossover point, it's going to be ipsilateral, same side as the damage. Okay. All right. Now, the anterior corticospinal pathway, this is the 10% of corticospinal axons that do not decussate. So this does not cross over. This just goes down on the same side the whole way. So this is where, since there's no decussation, if there's damage, it's going to be on the same side as the damage because there's no crossover point. So if I've damaged the anterior corticospinal pathway, which controls the muscles of the neck, the trunk, and the proximal limbs, it's going to be same side. It's going to be ipsilateral. Okay. So when in doubt, that's a kind of quick and dirty way that you could differentiate. Now, my other two structures I want us to pay attention to is upper and lower motor neurons, because this is also where we kind of can sometimes get confused. So upper motor neurons originate in the motor cortex or in the brainstem. So they're in either the brain or the brainstem. Motor cortex in the brain or in the brainstem. That's where they originate, upper structures, central nervous system. They're going to synapse with a lower motor neuron. A lower motor neuron starts in either the ventral horn in our spinal cord or in our cranial nerve nuclei. So they're either going to start in the brainstem or in the spinal cord, depending on wherever the upper motor neuron synapsed with it. The upper motor neuron first travels down, meets up with the lower motor neuron. Wherever that meetup point is, that's where the lower motor neuron starts. Okay. The lower motor neuron is what will then leave the spinal cord and will directly innervate the muscle. So lower motor neuron innervates the muscle, innervates the thing. So let's look at lower motor neuron. Lower motor neurons first are in the brainstem. If they're ones that are located in the brainstem, they will form our cranial nerve nuclei. While the lower motor neurons in our spinal cord reside in the ventral horn, they'll exit via the ventral root, and they'll then innervate our muscles, our skeletal muscles. Diseases that affect lower motor neurons are classically polio, botulism, and peripheral nerve damage. So those three are primarily lower motor neuron diseases. You'll see the classic flaccid paralysis in these conditions. Polio, botulism, and any peripheral nerve damage. So any damage to a peripheral nerve, just compression, injury. So you think of like your acute trauma that occurs to a limb or any structure outside of the spinal cord, think lower motor neuron lesion. Yeah, great. So some lesion symptoms, just to compare and contrast. Lower motor is LMN, upper motor is UMN. So lower motor has atrophy, muscle atrophy, versus upper would not have muscle atrophy. Think lower motor neuron, we can't get muscles to contract, right? It's a flaccid paralysis. So if we can't contract our muscles, they're going to atrophy over time. In lower motor neuron, it's going to be ipsilateral, so same side, because we're past the decussation point. We're at the point of where we're leaving the spinal cord, so it's going to be same side problems. Versus upper motor neuron, it's going to depend on if that pathway decussates or not. So it could be contralateral or ipsilateral, depend on the pathway in question. Lower motor neuron, again, we can't contract, so we're hyporeflexive. Versus upper motor neuron, we often can't control or we can't inhibit, so we're hyperreflexive. Lower motor neuron, we have fasciculations. Upper motor neurons, no fasciculations. And then again, lower motor neurons, we have low tone, hypotonia. Upper motor neurons, hypertonia, spastic paralysis, your classic tetanus, right? Versus lower motor neuron, Clostridium botulinum. And then upper motor neuron is where a Babinski sign would happen. So if you heard a Babinski sign, you know it's upper motor. It's going to be in your brainstem or your cortex, your brain itself. Okay. Let's see here. Okay, one more practice question. We'll take a little break for our last little push. So our question is, an abnormal result from this test may indicate a defect in which of the following structures? I may just look through and try to find, if I was doing this vignette, what the test would be. So I'm like looking through and it's like, oh, the neurologist asked the patient to stand with his feet close together, arms to his sides and eyes closed. What's that test? Romberg's, right? We oftentimes add this, right? We oftentimes add this, which is pronator drift, right? We oftentimes add that, but the test is this. This is Romberg's. So we're seeing if someone like can't stand with their feet together with their eyes closed. So they did a Romberg. And so if he had an abnormal result from this test, a defect could be in what structure? And so we can see the structures now, and then we can go back and look at the patient vignette fully. But we have cerebellar, either hemisphere or vermis. We have corticospinal tract, we have dorsal column, and we have spinothalamic tract. So we have lots of different tracts here. We've only thus far learned about the corticospinal tract, right? That's the only one that we reviewed. So this just shows you, this is my plug for, at minimum, these three are the three you need to review, okay? Know something about each of them. You don't have to know their whole pathway, but you should know what they govern. Like, what is their main kind of things that they're in charge of or responsible for? This is a key kind of anatomy question, okay? So if we're seeing a positive Romberg sign, we can kind of try to get some additional information, but it probably isn't going to help us. So 65-year-old male, he has Parkinson's disease, comes to neuro clinic, no symptom changes, he's on levo and carbidopa, he has a slight tremor, more prominent rest, diminishes with movement, and then we have potentially an abnormal Romberg's. So really the vignette didn't give us anything. He has Parkinson's, but ultimately it's who would be affected by Romberg's the most. We're looking for something that is going to be carrying proprioceptive information, right? That's going to be what Romberg's sign is, because it's putting your feet together and closing your eyes. Is, can you kind of tell where you are in space without that sensory input of vision, right? So are you able to do that? And if you aren't, then some type of issue with proprioception could potentially be gone. There's three ones here that kind of jump out at being potentially proprioceptive. First of all, let's rule out the ones that aren't. When we talked about the corticospinal tract, was there anything about proprioception in the corticospinal tract per se? Corticospinal tract is innervating who? Lower motor neurons and going to who? Skeletal muscles. Not, skeletal muscles can like help with proprioception, but it's not really giving us sensory input about proprioception. So I'd say less likely. The word spinothalamic tract, spine to thalamus, that's going upward, right? That's ascending pathway. And thalamus is stopping in the middle. Anything about that speaking directly to proprioception? What's the thalamus do in our brain? Yeah, it's kind of like the controller. The hypothalamus and the thalamus kind of control everything in the brain. They control who gets what signals. Who are we going to, really the thalamus is saying, what input are we going to send up to the cortex to make you consciously aware? Things go up to the thalamus all the time. The thalamus is like, I don't need to tell the cortex that we don't need to have conscious awareness of this thing. Like there's all these different noises and visual things. I can see all the cars going behind you, but I'm not paying attention to those cars when I'm lecturing. I'm paying attention to your faces because my thalamus is helping me block out that information because it's not important information for me to pay attention to right now. So less likely those two. So we have dorsal column, which really doesn't tell us anything outside of it's in the dorsum. So that's great. And then we have two things with the cerebellum. Now, normally I would say choose one of the cerebellar ones, right? Because that's dealing with proprioception. But in fact, in this question, it's dorsal column is the correct answer. So if we went just from, well, that word feels good, because cerebellum is proprioception and like where we are in space, that would potentially lead us astray. That's where really with the tract questions, the spinal cord questions, knowing what they govern will help you be able to decipher these answers. So let's kind of understand. The maneuver here is the Romberg, which is helping assess integrity of the dorsal column pathway. That's what it's doing of the brain and spinal cord. The dorsal column is who controls proprioception. So the cerebellum is getting information from the dorsal column. So that's who's controlling proprioception. Proprioception is a sense of awareness of position. Positive Romberg sign indicates sensory ataxia. Positive Romberg occurs oftentimes in dorsal column dysfunction. So that could be our tertiary syphilis, so Tabes dorsalis, subacute combined degeneration, which is just essentially long-term B12 deficiency. So when I see positive Romberg, I associate that with dorsal column. I associate that with proprioception. I associate that with B12 and potentially tertiary syphilis or anything that could cause then a B12 issue or dorsal column problem. Okay, but that's only because I studied those pathways, right? That's the knowledge that I would need. Okay. That's our micro / anatomy / physio dive for today.